So now we're going to practice the basic TTE exam. When holding the cardiac probe, there are two ways we can hold it: the pencil hold and the screwdriver hold. For our parasternal long axis and short axis view, we're going to use the pencil hold. You're going to hold the probe like a pencil, close to the base, and always be sure that you are stabilizing your hand on the patient's chest. For the apical and subcostal views, we're going to use the screwdriver hold. For the apical view, we're going to use an underhand screwdriver hold. The indicator will be towards the bed. I can use these two fingers at the base of the probe with these fingers stabilizing against the patient's chest, or I can use these two fingers to hold the base of the probe and use this finger to stabilize against the patient's chest in the apical forechamber. For the subcostal forechamber, we will still use the screwdriver hold, but we will be an overhand screwdriver hold with the indicator towards the patient's left. In the overhand screwdriver hold, again, you should stabilize your hand at the base of the probe and rest your hand on the patient's chest. As you obtain your ultrasound images, you may need to adjust the probe to obtain the optimal image. In doing so, there are certain adjustments you can make. You can tilt the probe, which is going to be moving the tail this way and this way. When I talk about tilting the probe, I usually talk about tilting the tail one way or the other. However, some people talk about which way the probe itself is being tilted. Another directional movement you can do is a rock. That's going to be moving the probe back and forth in this plane, which is the plane that has the indicator. Another motion is rotate, which is, as it sounds, rotating the probe back and forth. And the fourth is sliding the probe. Of course, as I begin, I can slide the probe to different locations on the patient's chest. So to review, we have sliding the probe on the patient's chest. We have rotating the probe. We can tilt the probe in this, or if you want to see it here, we can tilt the probe in this plane, or we can rock the probe in this plane. Now we're ready to begin our parasternal long axis view. We are on the left side of the patient using our left hand to scan, and the ultrasound machine is on the same side as the operator. I'm going to start with my pencil hold, holding at the base at the left lateral border. I'm going to start high with the indicator towards his right shoulder, and I'm going to slowly work my way down until I see something moving. Now I see something moving, but it's a lot of the aorta. So I'm going to continue down one more rib space until I get that typical parasternal long axis view. If in this view it is rounded, as we see here, I'm going to rotate my probe until I see the edge, until I see the apex kind of elongate onto the left side of my screen. If I see something like this, that means that I need to adjust my tilt to get my appropriate parasternal long axis view. If I see lung, as in this view, I'm going to try and come more medial to get that parasternal long axis view into plate. Once I have my parasternal long axis view, I'm going to steady my hand and use my right hand to reach across and rotate exactly 90 degrees to the short axis view. In doing this, I try not to change my tilt or my rock, but simply rotate exactly 90 degrees clockwise. Here we see a short axis view at the level of the mitral valve. I'm going to tilt the tail slightly towards the patient's right shoulder until that mitral valve is gone. And now I see my short axis view at the level of the papillary muscles, which is our typical FoCUS view. If I want to see the apex, I can continue to tilt the tail towards his right shoulder. If I want to go back up to the mitral valve and then the aortic valve, I simply tilt the other way. Now I'm going to move on to my apical four-chamber view. For this, I'm going to move to the underhand screwdriver hold. I, again, prefer to use these two fingers to hold at the base of the probe and these fingers to support. However, you can also use these two fingers to hold and this finger to support. The most important part is that you always have part of your hand stabilized on the patient's chest. In the apical 4-chamber view, again, I'm going to hold at the base, and I'm going to have the indicator towards the bed. That's at 3 o'clock. Oftentimes, I will rotate slightly counterclockwise, so my indicator is more at 2:30. And I'm going to push up at about this location until I see something coming into view. Again, this patient is flat on his back, because that is more in tune with reality and what we see in the ICU. However, it may give us some difficulty in getting our views. I'm going to go ahead and increase my depth and search for that the apical 4-chamber view. If I'm not seeing what I'd like to see, I can move more lateral and come almost up in the armpit to see if I can get a better apical 4-chamber view. As you can see here, we can start to see something coming in more lateral. This is also considered an RV focused view, where you can see a little bit where that right ventricle can be seen through looking at the left ventricle. The other option, if I can't see a perfect apical 4-chamber view with the patient lying flat on their back, is to position the patient such that they are tilted slightly towards their left. If that's not an option, the next thing I do is continue to march medially on the patient's chest. As you can see, now my wrist is becoming uncomfortable in this underhand screwdriver hold. Therefore, I'm going to switch to the pencil hold and continue to come medially. Now, I've got a picture that's almost a subcostal 4-chamber view. However, this allows me to view the right ventricular free wall and see that it is in fact coming in. I have good endocardial excursion, and my right ventricle is functioning appropriately. After my apical 4-chamber view, I'm going to move on to my subcostal 4-chamber view. Here, I'm going to do an overhand screwdriver hold with the indicator towards the patient's left. I'm going to go in the subcostal region slightly to the patient's right in order to include the liver as part of my acoustic window. Remember, your ultrasound beam is like a flashlight. So you're going to aim it such that it's going up to where we know the heart is in the chest. I'm going to increase my depth here. And now I have an apical 4-chamber view. RV, LV, RA, LA. If, again, you see the ventricle being slightly rounded, as in this position, you can rotate the probe in order to have the 4 chambers come into view. If the heart is off to one side, you can rock the probe to bring it back into the center. So rocking the probe will move your image from the right to the left side of the screen. The subcostal 4-chamber view is great to look for pericardial effusions. You can also do a short access view from the subcostal by putting that left ventricle in the center of the screen and then rotating exactly 90 degrees counterclockwise to see a short access view of the left ventricle. This is great in patients that are intubated, where I cannot get a good short access view across the parasternal or in the parasternal view because they're intubated on high PEEP. So I'm going to go back to the subcostal 4-chamber view. To move from the subcostal 4-chamber view to the IVC, I'm going to rock the probe to put the right atrium in the center of the screen. Then I'm going to rotate counterclockwise until my IVC comes into view. Alternatively, I can just take my probe and my pencil hold and place it on the chest about where the IVC should be. There we see the IVC dumping into the right atrium and the left hepatic vein. Remember that the IVC and the aorta are basically parallel to one another, and the aorta is on the left. If I want to obtain the aorta, I'm just going to simply tilt the probe, the tail towards the patient's right, so that the beam goes more towards the patient's left to find the aorta. To go back to the IVC, I simply tilt the tail back towards me or towards the patient's left to see the IVC. I always recommend finding both the aorta and the IVC to confirm that you are in fact looking at the IVC. Thank you for listening to this video.